Hello and welcome. My name is Chris Lynch. I want to welcome you and thank you for spending a little time with me here. I'm going to be sharing what I believe is going to be an exciting opportunity for quite a few of our clients who are currently on some Medigap plans to take a look and potentially consider switching to this Medigap plan in. The topics we're going to go over today include a little bit of the historical context regarding the plans that I'm sure most of you have, the older Plan Fs, and the majority of you probably have a Plan G. So what were those? What happened to the F? Why did we switch to the G? And why are we now kind of considering this move to an N plan? Also going to go over the in plan in terms of some premium examples. So how much can you save each month in terms of the cost of the plan, some of the coverage differences between the F, the G, and the N. And then finally, the next steps. If this is something that looks interesting to you, what do you do from here in order to, kind of pursue this opportunity? Really want to start with some historical context. Again, most of you, I'm sure, probably have the Plan F or the Plan G. And as a reminder, what these Medigap plans are designed to do is really cover the cost gaps that both Part A and Part B leave you with, right? So Part A, that inpatient bill, deductibles, per day copays. Part B, covering all your outpatient services, you have a deductible, and then co-insurance. So these Medigap plans, as a reminder, these are designed to cover those cost gaps that A and B leave you with after you've undergone some medical services. So if we go back prior to 2015, really for, 2006 is when these current Medigap plans were released. And in 2006 to 2015, kind of the Plan F was the top recommendation by far. And it was sort of easy to understand why. With your Plan F, those of you that are still on it, you ended up with a $0 deductible plan, zero copay, zero coinsurance, zero max out of pocket. All of your costs were really covered at 100% prior to you needing to meet any kind of deductible. So it was a very rich, very easy to use plan. It was one everybody wanted. And then what happened? So around that 2015 timeframe, we as advisors and the industry itself sort of said, hey, the government has passed a law and the Plan Fs are going to be retired January 1st of 2020. So if you're an individual and you turned 65 prior to January 1 of 2020, you could enroll in an F plan. You stayed grandfathered in with that right. But after January 1st of 2020, the F plans were no longer available if you turned 65 past that date. And what the industry told us as advisors was, hey, we see this coming in 5 years. Well, if we think about an insurance pool of Plan F individuals, nobody new is going to be coming into that. Over time, that pool is going to shrink. As people get older, we're going to see higher claims. And all those things really lead to increased rate increases. So we started hearing around that time frame, you might want to start talking to your clients and telling them the benefits of the Plan G, both currently and as we project the next decade out, what do those rate increases look like? And we expected the Plan F rate increases to be more severe, and that has certainly come true, right? So anybody who's in an F plan, if you could have gotten out of that due to some of those rate increases, that was probably the move you wanted to take. And then, so starting in that 2015 sort of time frame, Plan G became the recommendation. Yes, Plan F was still available, but we're going to tell you everything we know says Plan G needs to be the recommendation going forward. So we could do some math, show you why Plan G was the right plan at that time, and then say, hey, we really think these rate increases in the Plan G are going to be less expensive than what you're going to continue to look at on these Plan F, right? And that, again, that happened. The Plan Fs, multiple years of significant rate increases compared to the same Plan G. So now what's happening? Well, as advisors, we're starting to hear sort of the same thing for different reasons going on with the Plan G. So I feel like we've reached this inflection point with the Plan Gs, and maybe it's time for us as advisors to start really recommending the Plan Ns. Okay. So I'm kind of reliving the same sort of scenario and environment that I had in 2015 when we switched from the F to the G. And we'll go over some reasons for that. So, most of you, if you turned 65 from 2015 onward, probably in these Plan Gs, we're chugging along, fairly happy for a while, but maybe over the past couple of years, you notice that, hey, these Plan Gs, I'm starting to see year after year, I'm getting double-digit rate increases on these plans, right? And if we go back to COVID, even during some of the COVID years, there were some plans that didn't have any rate increase at all. It was a $0 rate increase. Very unusual, but why was that? It was because nobody was going to the doctor. Medical services were being put off. I'm sure everybody remembers, probably getting a rebate in the mail for your health insurance or your auto insurance. It's because claims weren't coming in. Well, we're a few years past sort of that COVID lockdown now, and all that pent up demand has really hit the carriers hard. So, if Plan G was the most enrolled plan, we've got a lot of people with this pent up demand. We've seen a couple of years of this post COVID sort of what they're calling a usage surge. So, while we had a few years there of low or maybe no rate increases, that's catching up to us now. It takes some time. It can take a year or two for the carriers to see what their claims were for the previous year, submit that data to the Bureau of Insurance, and get their rate increases in line. So, unfortunately, what we've seen over the past maybe a couple of years is out of the normal double digit, 10 plus percent rate increases on these Plan Gs. And the industry's telling us as brokers, you better prepare your clients that we see that going into the future, and maybe not here so in Virginia as much as some of these astronomical rate increases, but I've seen some carriers in other states have 30, 40% rate increases. I've seen carriers do 3 rate increases in one single year. So the Plan Gs have undergone a lot of rate increase pressure. Another reason for that is just higher than expected inflationary medical cost. A knee surgery now is exponentially more expensive than what it was 8 or 9 or 10 years ago. Technology has to do a lot with that, right? So you had a knee replacement 10 years ago. It's vastly different than what it is today with all these robot assisted surgery procedures. And because of that, just the baseline cost of medical care has really increased. And then what we're seeing with Plan Gs is, and this gets a little technical, but there's a reason somebody can enroll in a plan called a guaranteed issue. And the example I'll use is, let's say somebody lives in a different state, Florida maybe, and they have a Medicare Advantage plan down there. They decide to move to Virginia. So they can't keep that Advantage plan they had down in Florida. They move to a different state, they lose that, and they're over 65. Well, that doesn't really open up open enrollment for them. What it does is give them a guaranteed issue right to go get a new Medicare plan. And most carriers allow those guaranteed issue enrollees to enroll in a Plan G. So if you're eligible for the Plan G, turn 65 after 2020, your enrollment right is in the G. If you turn 65 before January 1, 2020, your enrollment right for GI, for guaranteed issue, is in that Plan F. So what that can lead to is some adverse selection, right? Because maybe this individual that wouldn't normally qualify based on their health, let's say they're on this Advantage plan, they're undergoing $500,000 worth of cancer treatment every 3 years. Well, when they're in this guaranteed issue right, uh, they have to be accepted. They can't be declined. They can't be rated up. So they get into the Plan G, and the plan has to immediately start covering all those expenses. So that's adverse selection. And that, again, can lead to the overall pool being a little more unattractive to the insurance company because of the higher claims. So a lot of the carriers we're going to talk about when we meet with you are going to protect that plan in pool. They don't allow the guaranteed issue into the plan in, right? So again, things were chugging along pretty nice for the Plan Gs for a while, but now we've sort of seen the shift in the industry, and it's maybe time to switch, start talking about a plan in. So we'll get to the premium examples on the next slide, but I wanted to first go over what are the coverage differences, right? So if Plan G was sort of the gold standard, what am I giving up by taking a plan in? There's going to be a trade-off here. So first thing is, remember, let's go over the Plan F, $0 deductible, zero copay, zero max out of pocket, no deductible from the first dollar. As a reminder, your Plan G, you have to pay the calendar year Part B deductible first. That's currently sitting at $257. And after you pay that $257, the Plan G covers you at 100% above that number. Same deductible with the Plan N. So if you're in a Plan N, you have that same Part B deductible, currently $257. But then after that, you've got some copays when you have certain services. So if you go to a primary care or a specialist, so some sort of physician office visit, you're going to be responsible for up to a $20 copay. I say up to because that's sort of the maximum copay. If the doctor charges less, it could be less, but we want to tell most people expect you go into, a sick visit, not preventive services, but a sick visit, primary care or specialist, either one, just sort of expect a flat $20 copay. So that's one difference. Now, the other difference is there's a copay if you go to an emergency room, and that's up to $50, right? Could be less based on what the ER charges and what the Medicare allowable rate is, but at the most, it could be $50. So again, you get admitted to the ER, just expect to pay a $50 copay. Now, that copay is waived if admitted, right? But that's our first difference between the N and the F and the G is you meet that deductible, $257, and then $20 copay for a physician office visit, $50 copay for an emergency room. Not catastrophic. And again, we'll look at some premium differences in a second. The second thing, and maybe this is the thing that initially might scare some people off, but it's excess charges. So excess charges is basically balance billing. A doctor can decide to charge up to 15% more than Medicare allows. Okay. And that sounds pretty scary. But let's go over some of the nuts and bolts of how this works. So the latest data is that of all the claims that Medicare processes, 99.7% come in without excess charges. So while I can't tell you you will never see an excess charge, what I can tell you it is statistically very unlikely, okay? So providers, 98% of all the providers that take Medicare do not charge excess charges. They accept the Medicare assignment allotted amount. And of those 98 providers that send in claims, if we take the 2% that don't, of all those claims total, 99.7% of all the claims come in without the excess charges. Okay. There's really two big reasons for why doctors don't typically charge excess charges. The first one is the amount Medicare is going to reimburse as soon as the doctor says, hey, I'm no longer accepting the Medicare amount, I'm going to charge these excess charges. Well, they reduce their reimbursement amount by 5%. So the doctor doesn't get to charge 15% more than Medicare's 100% allowable rate. He gets to charge 15% more than 95% of Medicare's allowable rate. So it's not the full 15% overage that he's getting. The next thing, and this is the bigger deal, is that when a doctor charges excess charge, he's no longer allowed to submit that claim to Medicare. So that means he's going to bill you for it directly. You're going to get the bill, you're going to pay that up front, and then you're responsible for going to Medicare and getting them to reimburse you. All right, now I don't know about you, but if 98% of providers accept Medicare and I don't have to pay that claim up front and then get reimbursed, and I go to a provider and I say, hey, do you charge excess charges? And they tell you yes, I'm probably going to find one of the other 98% of the doctors that I don't have to deal with that, right? That's a big deal to providers. The reason 98% of them take Medicare assignment is because they know they would lose patients if patients had to deal with this type of hassle, okay? So again, not impossible that you would never see an excess charge, but statistically unlikely. Now, if you're worried about your current providers, I would recommend you go to Medicare.gov, make sure .gov, not .com. You can go to Medicare.gov. They have a provider lookup tool there. Start typing in your doctors. If your doctor, if your facility, if your hospital shows up on that provider network, it means they automatically do not charge excess charges. Okay. Now, if you're going to do this, make sure you're using your names of your medical doctors. Sometimes the providers' search tools aren't great at things like physician's assistants, right? So make sure you're just using the right medical doctor or the name of the facility. And my guess is, again, statistically, you're going to go out there, just about all the doctors you're going to put in are going to show up. And it means that they do not charge excess charges. So why are we doing this? Well, we lower current premiums, right? So not only do we lower the current premium we're paying, but we're projecting in the future, plan in that cost gap, which isn't too bad today for a 65-year-old, but the industry's telling us, hey, those plan Gs, you're going to continue to expect double-digit plus rate increases while all these reasons flesh out, increased usage, everything fleshes out, multiple years, continuing in the future, projecting double-digit rate increases. They're telling us as advisors, we should expect the plan ends to continue around the 5% rate increase per year. Okay. So not only is it a lower percentage, you're starting at a lower number, right? So a 10% rate increase off of $130 is much more than a 5% rate increase off of a $95 premium, right? So the other thing about the plan in that helps keep its rate increase low is it is a little bit lower usage. You know, the fact that there's a $20 copay to go to a doctor will keep some people from going to the doctor, right? So automatically lowers some of the usage there. Lower usage, lower rate increases, right? It's insulated from that adverse selection of the guaranteed issue enrollment. So our person that moves from Florida to Virginia has cancer, he can't get into the plan in for the carriers we're going to be looking at, right? So we're doing this move to lower your current premium and protect you from some of these projected large rate increases on the plan in going forward. All right, so here's some real world examples of some of my clients that I pulled, age 70, 75, and 80, right? What does switching from a current plan G or a plan F that you've got to a plan N, what can we save you each month? So age 70 male, he's currently on a plan G. It's costing $174.70. I looked at the plan N quote, that'd be $115.42 for him, right? So not bad. It gets, significant as you go forward. And again, the caveat here is you're going to have your own current rate. You'll have your own end quote. These are different carriers, different ages. These people live in different places. So just take what you're seeing here with a grain of salt. When I say a 75-year-old, their current plan is $270.65. I can move them to a plan in for $133.04. Right? 80-year-old currently paying $230.89 for their plan G. A good plan in $171.51. Your results are going to vary. Do you qualify for a household discount? Are you male or female? Where do you live? What carrier are you on? And how have their rate increases been, right? But this just gives you an idea of the type of ballpark you could be in terms of saving each month. So let's look at our females, current age 70. She's on a plan G or 104.40. She can move to an N for 82.08. Right? But I've got somebody who's 75, female, paying 272.65. I can move them over to a plan N for 118.26. 80-year-old 307 on that G, move them to a plan N for 160.39, right? So everybody's can save some money here, some more than others, depending upon your exact situation. But, this is probably something you want to do some due diligence on and look into, right? Let us help you figure this out if this is the right move for you or not. All right, so next steps, you're getting an email. There's going to be an attachment with some of the things I've outlined here. You want to reach out to us, right? Call us. There's going to be a link in the bottom in the comments section of this video. Should be very easy for you to use. You're going to click that link, book a quick call for us, please review all the material first. We expect a high volume of calls. We've got a lot of these to potentially get through each month. So if you're interested, call us early, or don't call us, but book your appointment early. And please be prepared to have this discussion with us. Hopefully, we've answered most of your questions either in this video or the flyer that we're going to attach. And we can kind of help you through the process from that point forward. So, just a couple of caveats. Is this move right for everybody? No, it's not. It depends on your specific situation, right? So, if you go to the doctor a ton every month and you know you're going to be paying these $20 copays, those copays could certainly eat into the potential cost savings. So, this is not an everybody needs to do this situation. What are you on now? How are you using the healthcare? Does this move make sense? And that's what we could help you figure out, right? Now, the other caveat here is just because you want to do this doesn't necessarily mean that you can. So this switch requires medical underwriting. Anytime you're going to move from an N and a G to, or, move from an F and a G to an N, you're going to have to answer some medical questions. Now, there's no exam you have to get. Nobody's going to come out and draw your blood. But the insurance company is going to look at your health history. They're going to pull your medical records and they kind of decide on a case by case basis. No real harm in trying, right? If you get declined, there's no big deal. You just stay with the plan you've got. If you talk to us and you are declined, there's some rules Virginia's changing coming up in July that we still might be able to help you save some money. So no matter what situation you're in, whether it's switching to the inn or there's something called a new birthday rule coming out, maybe you talk to us about that and we help you switch and save some money that way. So again, you should be able to see the link in the flyer in the link in the video. Click that. You'll be able to book a call with us and we can talk to you about if this is right or not. All right. So hopefully this is exciting for everybody. Let us know, book an appointment with us, and we'll be happy to help you with this. I want to thank you all again for spending some time with me. My name's Christopher Lynch, and we look forward to hearing from you soon. Take care. Have a great day.